So the drug targets and classes we have are going to be for prophylactics. The idea is to stop them from being overexcitable, to try to avoid that forest fire burst to start. And there's many different drugs that Dr. Merlot will talk about, some of those prophylactics. There's anti-inflammatory drugs to try to block that inflammation. So we know about NSAIDs, that's good, blocks those prostaglandins. We're going to talk about triptans, which are one of the major migraine drugs. That's going to block inflammation and vasodilation. And then we have a relatively new drug class of different anti-CGRP drugs. So we talked about CGRP as like one of the major inflammatory mediators. And so if we can block CGRP action, then we could block those responses to inflammation and reduce the neuroinflammation and reduce the vasodilation that's occurring in the migraine. Am I going too fast? Okay. So here I say anti-CGRP mAbs. We'll talk about some different classes. mAbs are one of them, but there's also some antagonists. So basically, we could just look at these as anti-CGRP agents, and then we'll break them down into some smaller classes. But if you can stop the CGRP from happening, then that stops that inflammation. So you can't stop the inflammation. Can you do those rescue medications that are going to reverse the vasodilation? And so triptans as well, really lucky for us, those also block vasodilation. And caffeine is also a vasoconstrictor. So a lot of times people, when they start feeling that they're going to have a migraine, go for a cup of coffee or a Coke or Pepsi or tea. So you can hit the anti-inflammatory, you can vasoconstrict, or you can try to hit that interval by reducing inflammation that's just still in your brain. Because after you've had the migraine, remember you have that postdrome and you have just not feeling great for a while. Afterward, there's a lot of people who have migraines really frequently, just don't lose some of that inflammation. And so if you can get that inflammation down, then you would be less likely to have another migraine, or that next migraine might not be as bad. So those prophylactic drugs that Dr. Merlot is going to talk about, their whole goal is to reduce the excitability of these neurons that are involved in migraine. Our pharmacologic goal would be to reduce the excitability only of migraine neurons and nothing else. That goal will not happen. So we're using a lot of drugs that were made for other disease states that just seem to reduce those overexcitability. And basically, I'm just going to give you and say, you're going to have some antiepileptics, you're going to have beta blockers, you're going to have Botox. Those are drugs that are not going to be specifically made for migraine, but they're reducing this overexcitability. So if I'm asking you what's the mechanism of any of these, your goal is to say, reduce overexcitability, reduce a migraine or prevent a migraine from starting. So let's go and look at those a little bit more carefully about the inflammatory response. So we can look at the acute inflammatory stage where you had, let me draw this out again. So you had the interictal, then you had the aura, oh no, sorry, you had the prodrome, then you had the aura, then you had the pain phase, then you had the postdrome. So when the aura starts is when all that inflammation is starting. At the beginning of the aura is when you get that forest fire that's really just hits it and starts going. And that's when the inflammation is going to, inflammatory mediator release is going to start. So if you can get an anti-inflammatory drug, that would be awesome. We have anti-inflammatory drugs. Can you guys tell me 2 classes of anti-inflammatories? NSAIDs. And one that we haven't covered in IST, but we talked a little bit about before, were the corticosteroids. That would be pretty hardcore for a migraine inflammation, but some people who have like 6 migraines a week do end up taking corticosteroids. And then, so we have anti-inflammatory drugs that are ones we're used to for different, developed for different reasons. And we have the triptans that were developed specifically for migraines. And the triptans are going to both reduce the inflammatory mediator release, and they're going to cause vasoconstriction. So those are the ones that that is amazing what they do. If they can reduce inflammation and cause vasoconstriction, then they're hitting 2 of the major parts of migraine pathology. And remember when we talked about those inflammatory mediators, we talked about CGRP and prostaglandins, but we were just kind of generally calling the prostaglandins and all that stuff inflammatory mediators. And those really were the ones that were produced by COX enzymes. So NSAIDs and triptans and corticosteroids, their mechanism is to decrease an inflammatory response. We have some new drugs that are also anti-inflammatory, but those are prophylactic, so they're given constantly. And those are drugs that decrease CGRP responses. And since they're prophylactic, they're on constantly. And the goal for those is if you can just reduce the general long-term inflammation, you're going to be less likely to hit a threshold and start a migraine. And if you do start a migraine, you're not going to have as much residual inflammation, so it might not be as bad. So those acute anti-inflammatory, what you take while you're having the migraine, anything that you can take that's anti-inflammatory, including NSAIDs or triptans, are going to reduce that inflammatory response. And if you want to look at it prophylactically, these anti-CGRP agents can reduce the residual long-term CGRP inflammation. So that slide was how these agents can act as anti-inflammatories. What can do anti-inflammation? Here's the other side of it, the other mechanism, which is vasoconstricting. Because we were hoping we could do one, the other, or both. So the 2 agents that are most commonly used are triptans or ergots. I don't think that ergots are barely ever used anymore. Dr. Merlo will answer that, but she is nodding. Those were original. Some places they have them on the formulary, but I don't think they really use them. So I'm not going to make you memorize ergots. I want you to know triptans. Those are the guys that we said block the inflammatory release and cause vasoconstriction. And then caffeine as well as a vasoconstrictor. This is a really cool diagram where they had, this is either rat or mouse, a rodent model. was imaging one of the cerebral blood vessels. This was vasodilation when they gave an inflammatory mediator IV to try to cause vasodilation. And this is that when they just put a triptan in afterward. So that's a pretty clear, obvious vasoconstriction from that triptan. It's really good, and this is very important in terms of the mechanism, that they're fairly selective for the vasculature in the cerebral vasculature, so in the brain. If you take a triptan as prescribed, it should really only be vasoconstricting in the brain and not in the periphery. So if you had vasoconstriction overdose and you took 5 doses of the triptan and you're vasoconstricting, what would happen if you over vasoconstricted in your brain? I know someone over here knows this. Too much vasoconstriction in the brain, less blood flow, ischemic stroke. In your heart, you have vasoconstriction, not enough blood flow. What is that? I have to tell Dr. Spearkey. MI. Yeah. And what if it happens in your limbs? Peripheral ischemia. So anything that's a vasoconstrictive disorder, taking large doses of a vasoconstrictor would be a problem. Okay, so the actual molecular mechanism of action of triptans. So I've already told you like 3 times that triptans inhibit inflammatory mediator release and triptans cause vasoconstriction. But let's see how. Triptans are actually one of the cleanest drugs that we have, neurodrugs. They really are fairly specific to 5-HT1B and 5-HT1D receptors. That is amazing when it comes to a neurodrug. 5-HT1D receptors are on the presynaptic. So let me tell you what this neuron is. This is that cortical neuron. Here, let me draw it in black. This is that cortical neuron that we said got overexcitable and released inflammatory mediators. If we have these 5-HT1D receptors presynaptically, if you activate them, then you're going to block inflammatory mediator release. The blood vessels have 5-HT1B receptors, and if you activate those, that causes vasoconstriction. So those 2, let me say them again, activation or agonists of these presynaptic 5-HT1D receptors inhibits release of inflammatory mediators. Activation or agonists at 5-HT1B receptors causes vasoconstriction. So, triptans rock. Should they be an agonist or antagonist at 5-HT1D receptors? Agonist, right. Because the agonist is going to inhibit the inflammatory mediator release. And how about at the 5-HT1B receptors? Agonist or antagonist? You know what? Yes, you knew it. You just didn't want to say. Yep. So basically, triptans are agonists at 5-HT1D and 5-HT1B receptors. I'm not going to hold you responsible for knowing which receptor causes vasoconstriction and which causes really reduction of inflammatory mediators. You just need to know these drugs at 5-HT1B/1D receptors cause vasoconstriction or inhibit release of inflammatory mediators. You don't have to match the receptor to the effect. So the triptans, here we go, 5-HT1B agonists, two effects, inhibit inflammatory chemical or inflammatory modulator release, cause vasoconstriction. That blocks inflammation, blocks vasodilation, and reduces pain. And that's what you want. So there are multiple triptans, and they, lucky for you, all end in triptan. And you're going to be talking about this with Dr. Merlot, but we already talked about vasoconstriction. Can you just predict some of the contraindications? Cardiovascular disease, anything that's a high stroke risk. You're just thinking about constriction, right? You're thinking about that logically. Too much vasoconstriction, we know those are some specific disease states that put you at risk for that. So we talked about triptans. Now we're going to talk about those CGRP agents. There's three, but we're going to break it up into two because we're going to put two of them together. You have, so this is the CGRP receptor down here in blue. Over here, we have simple antagonists. If you just bind that receptor and block it, then CGRP cannot do its thing. And you're automatically anti-inflammatory. So CGRP receptor antagonist, anti-inflammatory for CGRP signaling, not for COX or prostaglandins or anything, just for CGRP. And if they're given prophylactically, going to decrease that general inflammation that's happening in the area. These guys are not MABs, and they can be taken PO. If they were MABs, could you take them PO? No. So these guys are nice because they're not MABs. I'm going to have you look at this diagram here. So look at it before we go to the next slide. There are two drug classes that are antibodies. One is antibody to CGRP itself, and this is wild. I don't know of any other drug that's an antibody to the signaling molecule. They're antibodies to the receptors, and in this case, you have an antibody to the CGRP receptor. It's not an antagonist because it doesn't bind the binding site. It just blocks the whole thing. The antibody's big and it binds and it's just huge and it just keeps CGRP from binding. So we're going to go to the next slide and you're going to remember this diagram. Antibodies that bind CGRP itself and ones that bind the receptor. So the diagram here, it's really saying the same thing, but probably not as good. Here's the cell, here's the CGRP receptor, here's CGRP, and if you're taking that anti-CGRP antibody, it's just binding the CGRP and just pulling it away. It can't bind. The CGRP is not going to attach to the receptor anymore. So I'm kind of putting these together, whether they're binding the receptor or binding the peptide neuromodulator. I just want you to know that they're anti-CGRP signaling. So I'm going to write that down, anti-CGRP signaling. Dr. Merlot, do they need to know, in your opinion, which ones bind the receptor versus the peptide? Is that useful?
I don't think so.
Dr. Merlot herself. You have to know they're all MABs. You have to know they all block CGRP signaling. And whatever Dr. Merlot is going to teach you. So these guys, all MABs block. I might ask you when I say mechanism of action, can they block CGRP peptides? Can they block CGRP receptors? I'm not going to have you specifically go to one or the other and say, you know how to say this, Erinuma, I can't say it. Which one binds the CGRP receptor and which binds the peptide? So this is going to reduce long-term inflammation and reduce migraine occurrence. Remember, these are prophylactic and you're interrupting the residual inflammation. And we'll just do this one question and then you will have your break for Dr. Merlot to start. So why would Aimovig be available IM but not PO? Because it's a MAB. Yes, I saw you. And do you want to block inflammation in the postdrome, or would you like to block it at the aura phase if possible? Aura, because that, I mean, sure, it'd be not, you might take Advil in the postdrome just because you still have inflammation, but anything that's that is trying to reduce that inflammation, reducing the neuro inflammation and the pain signaling and the aura signaling, and getting that as soon as possible. Dr. Merlot would talk about how he utilized those rescue meds, but the reason, the pathophys for doing that as soon as possible is that if you can stop it before you get the vasodilation, before you get all the inflammatory release, then you're stopping it early enough to really have more efficacy. The later you go, the more inflammatory release has already happened. So that's the pathophys for why you want to take them early. And we are done and come back at 5 after, and Dr. Merlot will start. That was sweet. That was like perfect timing.